I would like to thank the WCLL organizing committee to choose this abstract, and it's a great privilege to present that on the behalf of all the investigators from Clarity study. So this study primarily was looking at the primary endpoint, which was the minimal residual disease, so MRD eradication less than 0.01% in the marrow after 12 months of ibrutinib and venetoclax. There were the secondary endpoints, which included looking at MRD eradication in the marrow after 6 months of combination and 24 months of combination. There were other key secondary endpoints, including response rate, PFS, and OS, and a few exploratory endpoints, which would be presented in a later presentation. The key entry criteria was typical. These were relapsed refractory patients. If patients had 17p deletion and they had 1 prior lines of therapy, they were allowed, and they had to have an ECOG status of 0 to 2 with adequate bone marrow function, but patients, if they had marrow involvement, which they were allowed to be included in the trial. These are the key exclusion criteria are tabulated there. So this was the treatment schedule. So initially the patients got 2 months of ibrutinib, so to debulk the disease, and then venetoclax was given as an escalation that we normally do from 20 to 400 milligrams. And then there was a combo for 12 months, and essentially that's the primary endpoint of the trial, whereas these were the exploratory endpoints, 8 months and 26 months. Today I'm going to show you some data on the 24-month endpoint as well. So the patients, they were MRD duration of therapy rules, so MRD negativity at month 8, patients were stopping therapy at month 14, and patients who became MRD negative at month 14 or 26, they will start I+V at month 26. MRD positive patients were allowed to continue ibrutinib. So these were the patient characteristics. So these were heavily pretreated patients. There were actually 54 patients who were enrolled. 4 patients had to stop ibrutinib before starting venetoclax due to toxicity, and primarily the reasons were infections, vascular disorder, and 1 patient had severe diarrhea. So 50 patients were recruited. Patients had bulky disease. Majority of the patients had unmutated IgHV, and had a majority of the patients also had previous chemoimmunotherapy and had relapsed with chemoimmunotherapy or within the last 3 years. So this was the primary endpoint data, which was presented by Pete Hillman at ASH, and essentially it was showing that the bone marrow MRD negative rate was 40% at 12 months of combination, and it was very favorable. We have changed the trial slightly now, and essentially I talked about that in my previous presentation. So the patients who are still MRD positive at this stage are allowed to now get venetoclax for another 12 months in combination with ibrutinib, and we'll see if there is any improvement in the MRD negative rates in these patients. So this is the 26 months data now, and we've got mature data for 46 patients, and the bone marrow MRD negative rates continue to improve in these patients with combination therapy, both in the peripheral blood and bone marrow. And essentially, what we are seeing also is the patients who stopped, who became MRD negative at 8 and 14 months, 16 out of 17 those patients reaching month 26 are still MRD negative up to date. This is just in the tabulated form at the MRD negative for less than 0.01%. It is in peripheral blood, it's 70%. In the bone marrow now we're seeing up to 50%, and the less than 0.001% are tabulated there. This is the swimmer plot for the patients who are continuing with ibrutinib at present. And as I said, some of the patients have continued ibrutinib and venetoclax. So the blue plot is the ibrutinib, the purple one is the ibrutinib and venetoclax, and then the patients will go back onto ibrutinib. So you can see some of the patients here, and the black dots are becoming MRD negative at month 26, and they will stop therapy once we confirm that they are in MRD negativity. These are the swimmer plots for the patients who've stopped therapy, and you can see that the patients, quite a number of patients are off therapy for some time now. In terms of the IWCLL responses, the overall response rate is 96%, which is persistent, and patients continue to do extremely well. In terms of this toxicity, we have not seen any major toxicity, really. The main one that we expected was neutropenia, and that was seen in 11% of the patients. Apart from that, the usual atrial fibrillation, not many events, and majority of the patients are doing fine. There is only one case of tumor lysis syndrome, which was biochemical tumor lysis, and patients, there has been no major issues with respect to that. We had one case of Richter's transformation. So this is a case, patient diagnosed in 2011, treated with FCR before, and a Fisher 13q deletion, and he had a VH321. The patient achieved MRD positive CR on Clarity study, but then developed nodal disease 2 years into treatment, and the PET-CT was highly suspicious of transformation and required, patient had R-CHOP with a short-term response, and then had CNS progression and died in May 2019. So to conclude, combination of ibrutinib with venetoclax is very well tolerated in relapsed refractory CLL. We have just seen one case of laboratory TLS. Adverse events are usually minor, and a majority of the patients have had a very good objective response. 40% of the patients were MRD negative at 12 months of therapy, which has increased to 50% now, and the peripheral blood MRD negative rates are improving as well. Due to this trial results, we have modified our NCRI phase 3 FLAIR trial, and we've only seen one case of Richter's transformation. And I would like to acknowledge all the patients, and I would like to acknowledge all the Clarity team, essentially from multiple sites who've been sending us samples. It has been a team effort. CTRU in Birmingham, who have been supporting the trial, and HMDS, who's led by Andrew Ross. Andy is doing all the fantastic lab work. Thank you very much.
Thank you very much for this presentation. We have time for questions. I would be interested in the neutropenias you have observed. Do you also capture how frequently G-CSF is used with a double combination? Because as far as I know, there are not so many data on G-CSF use in the combination available.
G-CSF was allowed quite frequently on the study, so we had minimal interruptions, and I cannot tell you exactly, but it was very frequently used in the combination. It was used early on primarily, and later on the requirement went down.
If there are no questions, thank you very much again.
Thank you.